I think it's very important for all clinicians who treat NMOSD patients to become intimately familiar with the three approved therapies. Now, approval depends on country, so I'm just going to refer to the FDA approval, which I'm most familiar with. I understand the situation in Europe is evolving right now, and that two of the therapies currently have approval by EMA, and the third, Inebilizumab, has a provisional approval, but should become approved by the end of the year. But in the U.S., we have three U.S. FDA-approved treatments. It's important for clinicians to understand the outcomes of the clinical trials, the investigations that were done, and the indications of each of these medications, as well as their adverse event and risk profile. So, for example, there's a REMS program with one of the products. It's very important for anybody who's going to be prescribing a complement inhibitor to understand the critical importance of the REMS program associated with that. And then the same applies really to Inebilizumab and Satralizumab. These products also have unique risk-benefit profiles, and it's just very important for clinicians to be aware of all of these. In my personal opinion, I think that we have gone from a time where we had no approved therapies and where we're using empirically based treatments into now a time where we have three approved products. I personally feel that because of the weight of the evidence of the approved products, clinicians should be making decisions based on treatment paradigms where the FDA-approved products are presented frontline to patients, and that the older treatments that we used to use all the time, such as mycophenolate mofetil, azathioprine, Rituximab, to be reserved for patients who have failed to respond to the approved therapies. In general, I think my preference is to use approved treatments over not approved empiric-based treatments because of the weight of the evidence and because one can appropriately describe the risk-benefit profile to one's patients.